jeringas, tus tiras reactivas.
Hemsley Charitable Trust is a global philanthropy focused largely on health. We work in partnership with an international NGO called Life for a Child, and they work in over 40 countries. In Guadalajara, they partner with the Mexican Diabetes Association.
Afortunadamente tenemos el programa de Life for a Child que apoya a estas familias de bajos recursos con tirillas para estarse midiendo la glucosa, con medidores, con lancetas.
Type 1 diabetes is very difficult to diagnose, especially in low and middle income countries where you also have a high burden of communicable diseases.
En la diabetes tipo 1 es necesario administrar insulina y checarse sus niveles de glucosa varias veces al día.
En total serían 5 inyecciones al día aproximadamente, dependiendo cómo ande mi azúcar. Son cosas con las que tengo que vivir diariamente. Y si hay aceptación a lo que tienes que hacer para estar bien contigo mismo, pues siento que no lo ves de una mala manera.
Todos mis juguetes tienen diabetes. Butch es mi peluche favorito en todo el mundo porque tiene los lugares donde se tienen que inyectar. Juego a que lo inyecto.
Tener diabetes no es culpa de nadie, pero la gente piensa que nosotros somos, yo creo que los principales causantes de la diabetes en nuestra hija. ¿Qué hiciste? ¿Qué le diste? ¿Tomabas mucha coca? ¿Le dabas muchos dulces? Hay mucha ignorancia.
The conversation around non-communicable diseases has largely revolved around preventing these diseases and about changing your habits. But really, for autoimmune diseases like type 1, there is no way to prevent them.
El impacto que ha tenido en mi familia la diabetes, siento que ha sido único. Mi hermano todo el tiempo me pregunta, ¿cómo estás? ¿Te sientes bien? Mi hermana estudia nutrición y después hace su diplomado en educador en diabetes. Y con mis papás son mis héroes. Sin ellos no sé si seguiría vivo.
Yo hoy en día ya no tengo miedo porque mi hijo ha aprendido a cuidarse. Corre, brinca, salta, juega fútbol. Estoy feliz porque mi hijo está sano.
Mi hija me da esperanza. Verla sonreír. Ella es feliz, ella cree que todo lo bonito que le pasa en su vida es la diabetes. Los únicos límites que vas a tener en tu vida son los que tú te crees.
Thank you very much. Good morning, everybody. Good afternoon and good night. And thank you for the fantastic film, Living Without Limits, winner of the WHO Health for All Film Festival. So I would, without further ado, introduce Dr. Ren Mingui, Assistant Director General for the Universal Health Coverage, Communicable and Non-Communicable Disease, who wants to set the scene for this announcement of the Global Diabetes Compact on the eve of the World Diabetes Day.
Thank you, Bente. Distinguished guests, dear colleagues and friends, good morning, good afternoon, and good evening. The year 2020 had exposed tremendous global fragility and vulnerabilities, but it also helps show in today's world, we need global solutions to global challenges, whether it is in defeating the COVID-19 pandemic or tackling the diabetes epidemic. Both crises are colossal and point to the need for a new, effective multilateralism to provide global governance on issues that concerns us all. Medicines like insulin, technologies like routine diabetes test, and care like routine diabetes counseling provided by a nurse are three very important and critical instruments to bring diabetes treatment to all who need it. It is essential that they are available and accessible in both quality and quantity to all. 1 in 5 persons who are aged over 65 have diabetes and need diabetes medicines, technology, and care. 4 out of 5 persons with diabetes living in low and middle income countries are undiagnosed because of lack of coverage of routine tests or inability to pay for them. COVID-19 continue to expose and exploit these inequalities. Persons with diabetes has a higher susceptibility to COVID-19 infections and has a higher case fatality rates. Delays in diagnosis diabetes are resulting in more advanced disease stage and complications. Interrupted treatment of diabetes can be life-strengthening, and an increase in behavioral risk factors, such as physical inactivity, can be detrimental for a person with diabetes. We cannot leave this situation any longer, and we must emerge from this pandemic on a path of true and lasting sustainable transformation. That's exactly why today we are announcing the launch of WHO Global Diabetes Compact on April 14, 2021. The governments need to align COVID-19 recovery and stimulus plans with diabetes care. That means investing in people and in primary health care and universal health coverage. Do not blame out on implementing policies, legislative and regulatory measures that aims at reducing premature mortality from diabetes. This includes increasing effective taxation on sugar-sweetened beverages. I'm encouraged that the Global Compact will include the pharmaceutical industry. We will be asking for meaningful and effective contribution to the implementation of national diabetes response. We will publish a list of asks similar to what we have done for the food industry and will shortly be doing for the alcohol industry. I count on the pharmaceutical industry to help get us in a better place with renewed global solidarity. But more is needed. Global cooperation must be part of Global Compact. Norway announced yesterday at the renewed World Health Assembly that it will contribute additional $133 million from the year 2020 to 2024, with aims to reduce the burden of NCD in lower income countries. We call on other OECD DAC members to take inspiration from Norway and shape their strategic direction, align their policies, portfolios, and pipelines with SDG targets 3.4 on NCD and 3.8 on universal health coverage. We need speed, scale, and decisive leadership. I count on all the stakeholders to rise to the challenges and make this coalition a big success in saving people's life from diabetes. Thank you very much.
Thank you very much, Dr. Ren. I want to show you a few slides, and we will make them available after the event as well. So give me the first slide, maybe, Menno. So what is important is that the COVID-19 has, as Dr. Ren already says, laid bare the situation for people living with diabetes. So there has been a deadly interplay where people living with diabetes has had more risk for becoming severely ill and die. They have gone undiagnosed, untreated and also unprotected because of lack of healthy food, lack of physical activity, and also a pressure on other unhealthy risk factors. So as Dr. N said, there has been 100 years of neglect when we are now going into the centenary of the insulin. So we know already that many people with type 1 diabetes do not have access to insulin. And 1 out of 2 of the 60 million people with type 2 diabetes who need insulin do not get insulin either. So we need to support especially the low-income country who hasn't got the basic technology and very limited access to healthcare system and health professionals a better life. So what we need to do and why we are announcing this global compact today is really to call on the power of partners around a common diabetes agenda and mobilize all hands on deck. So we want to focus on prevention and diagnosis and with a specific look at obesity in children and adults. We want to monitor and measure. We want to provide quality care, and we have the vision to reduce the risk of diabetes and ensure that all people diagnosed with diabetes have access to quality care and treatment, but that this is also equitable, comprehensive, and affordable. So we hope to see a real game changer 100 years after the discovery of insulin with 6 different game changers. I will not go into this now, and I will go to the next slide. So as Dr. N said, today it's an announcement. And between today and April, we know that there will be activities. We know that member states want to step up the actions for diabetes, and we will call on all partners to join us in this journey. So nothing with us, without us. And this is something we really want to emphasize through the whole Global Compact. And I'm very honored to have 2 people with us today. Daniela Rojas Jimenez, who is an educator, and also Dr. Victoria Pickney Atkinson. Daniela has a type 1 and Victoria a type 2. And please, Daniela, take the floor and give us your expectations of the compact.
Hi, thank you so much for having me here. And well, first of all, my name is Daniela Rojas. I have lived with type 1 diabetes for 28 years now. And today, what I would like people to understand the most is that people who, like myself, live with type 1 diabetes are unable to live without access to insulin. People often don't understand this. And I think it's imperative that people understand that not only we need insulin, but we also need proper management to understand our condition. We need test strips, we need glucometers to actually understand if the insulin we're putting in our bodies is doing what properly needs to be done. If not, we won't know if what treatment is working. We won't understand when to react to hypos or hyperglycemia. We won't understand if what we're doing is actually helping us stay safe. And this is important because we don't often understand that if we do not have proper management, we can actually be in danger of having short-term, medium-term, or long-term complications. This is why people with type 1 diabetes and type 2 diabetes not only require access to insulin, but they also require diabetes education and a multidisciplinary team to work along with them to help them understand the way their body reacts, the way we react to meals, to exercise, hormones, stress, emotions, and so much more than actually goes on a person's life on a daily basis. Because what I find ironic is that without education, actually access to insulin can be dangerous, even life-threatening. That is why it is so important that we get both. Because if not, also, whenever you read a number, it would make no sense to you. You won't be able to understand what's happening to your body. And it can really take a toll on your emotional, on your mental health, and of course your physical health. And it can really make your treatment and living with it a true burden on an everyday basis. Therefore, I believe that today I would love people to understand that the nutritional, the psychological, and the medical teams should be a pillar of diabetes education. I am very hopeful and very grateful to be here today because I believe the WHO Global Diabetes Compact actually is proving that people are committed to change this. You're actually giving us a platform so that our voices can be heard, so that people understand what type 1 and type 2 diabetes is. We can actually have an opportunity to actually educate people who don't know anything about this condition and that are actually maybe personally, professionally, and politically related to it, so that we can all work and make a change. And in order for people like myself to be safe in their own skin. Today, I hope that with this program and with the WHO is actually, we're gonna create awareness of what diabetes really is, to actually bridge a gap between the diabetes community, between our governments, between our healthcare systems, and our general populations. Because my biggest hope is that no matter where you live, no matter where you've been raised, no matter where you were born, you actually have access to insulin, and that no one dies because of lack of it. People, I hope, understand that diabetes education goes beyond the diabetes community in order to also prevent discrimination, missed or late diagnosis, that today it even causes death. And I hope that all the governments around the world actually understand that people living with type 1 really need access to insulin, that is not a luxury, that without it, we cannot see the light of day, that it's really what we need to stay alive every day. Thank you so much.
Thank you very much, Daniela. And we move to you, Dr. Victoria Pinckney Atkinson.
Hello, it's Vicky here. My name is Vicky, and I am a person living with type 2 diabetes mellitus. And I live in South Africa, where the leading cause of death in women is diabetes mellitus. And it isn't a new thing, it's been going on for a long time. And I count myself very lucky to have been diagnosed with type 2 diabetes, because most people in Africa don't get diagnosed. And I was very fortunate to be diagnosed. And so now I'm on treatment. I have 2 kinds of insulin and 2 kinds of pills. And so that is quite a tricky thing to manage. But fortunately, along the way, I was a diabetes clinical nurse specialist. I was a pioneering diabetes nurse specialist 40 years ago. And that helped me when I surprisingly became diabetic. And I'm well controlled now. It's taken 7 years. And it's through, as Daniela was saying, it's a combination of exercise, nutrition, and medications. But it's also much more than that. I'm very lucky I don't have any of the long-term complications. But when my blood sugar is low or high, I really have problems with my brain. And so sometimes I can do some really dumb things when I've got a high blood sugar or a low blood sugar. And so now I'd like to just tell you a little bit more about it. During the COVID epidemic, I've been running a helpline and working with people to assist them. And I was in the middle of transitioning from private healthcare to the government healthcare, because I no longer can afford to buy the medicines in the private sector because it takes up half of my pension. And so COVID came along, and there was no chance of me getting the right care, because it means to get insulin, I have to go to a second level hospital to get insulin. And also the long queues, and it puts me at risk of getting infections. I have other non-communicable diseases. I'm an NCD's activist, so I really knew what was going to be happening to me. I've got very lucky that I have this care at the moment. But when I go to the public sector, I know that I have to go to a regional hospital, a high-level hospital, to get the insulin. I can't get the same insulin that I buy now privately. It's an old insulin with an old way of delivering it. I probably won't get the test strips because type 1, type 2 diabetes only get half the number of test strips if they're lucky, if they're in stock. The medications that I have, one is the same, but it's a long-acting, short-acting form that's very toxic to the bowel. And the other one is not available at all at the moment. So there are plenty of barriers to healthcare. If I had HIV, I would be able to get streamlined care with input from a trained health staff, and I would be able to get 3 months of lots of insulin, 3 months worth if I was controlled. As a diabetic, I can't get any of that. So it actually, in some ways, it sounds terrible. It would be better that I had HIV than diabetes. And that is true for many places in Africa and in the developing countries. So what patients are hearing is, I'm sorry, we can't help you. We haven't got any test strips, or we can't help you because there's no medicine in stock today. And so now what we're looking forward to is this global diabetes compact can make a huge difference. If we can get policymakers to get on the same page and treat diabetes as seriously as they do for HIV, TB, and sexually transmitted diseases. That's what we want. That's what we need. We need to stop the conspiracy of silence. And we also need for people like me and like Daniela and the millions of us out there to be included in the compact that is developed, included in the care, and stop treating us as if we don't exist. Thank you. Nothing about us without us.
Thank you, both of you. Very, very strong and encouraging messages. We will now move to a very important statement in the celebration of the World Diabetes Day on the discovery of insulin and also accelerating progress as a moral imperative. So Antonio Guterres, the United Nations Secretary General, has sent us his statement, and we are very, very happy that Julie Evans, a WHO staff with also type 1 diabetes, has agreed to read the statement. The floor is yours, Julie.
Thank you, Bente. So good morning, good afternoon, good evening, everyone. Many efforts have been made to prevent and treat diabetes, yet the number of people with diabetes is going up. What's more, it is rising most rapidly in low and middle income countries, the countries least well equipped with the diagnostics, medicines, and knowledge to provide life-saving treatment. The COVID-19 pandemic has brought additional pain. Many people who require regular care and treatment for their diabetes have struggled to access that care. And people with diabetes are at an increased risk of severe disease and death from COVID-19. Next year, the World Health Organization will launch the Global Diabetes Compact, a new initiative that will bring structure and coherence to our complementary efforts to reduce the burden of diabetes. Let us work together to make sure that through this ambitious and much needed collaboration, we will soon be talking about the decline in diabetes as a public health problem. And as we strive to overcome the pandemic, let us do our utmost to ensure universal health coverage, strengthen health systems, and advance good health and resilience for all. Thank you.
Thank you very much, Julie, and thank you to Antonio Guterres' statement. The next one is a video address from our Director General, Dr. Tedros Adhanom Ghebreyesus.
Dear colleagues and friends, more than 40 million people are diabetes. And this number is...
So we don't hear any sound.
Dear colleagues and friends, more than 40 million people are living with diabetes, and this number is growing, particularly in low and middle income countries, which in many cases do not have access to even the most basic technologies for diabetes diagnosis and management. Access to essential medicines, including life-saving insulin, is alarmingly low. Too often, diabetes is a condition that goes undiagnosed until complications arise. It's a major cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputation. While diabetes has been on the rise for many years, this year has been a wake-up call. People living with diabetes are at increased risk of severe disease from COVID-19. In addition, health services and supplies of medicines for people with diabetes have been significantly disrupted due to the COVID-19 pandemic. We can and must do better. We must improve our coordination to support countries to make the policy and fiscal decisions that can prevent diabetes, to provide them with the guidance and tools that they need to provide care at the primary healthcare level, and to work through all the channels necessary to help make diagnostics and medicines affordable. 1 year ago, WHO launched a pilot program to pre-qualify human insulin to increase treatment for diabetes in low and middle-income countries. To coincide with the 100th anniversary of the discovery of insulin in April next year, WHO and partners plan to launch the Global Diabetes Compact, a new initiative to define a global coverage target, a price tag, new technical tools and guidelines, and mechanisms to drive innovation. A particular focus will be to bridge the gap between people with diabetes who have access to insulin and those who do not. In the meantime, during this year of unprecedented challenges, we must strive to provide treatment and care for as many people living with diabetes as possible, and continue our journey towards a healthier, safer, fairer world for everyone, everywhere. I thank you.
Hi, good morning, good afternoon, and good evening to all. It's such an honor to be here. My name is Sylvia Kalenbrink, and I'm the Director of Global Endocrinology at Brigham and Women's Hospital in Boston. And first of all, I would like to express my gratitude to the World Health Organization for organizing this incredibly important event, for your leadership and dedication to improving diabetes care globally over the years to come. We're extremely grateful. And it's a distinct honor to introduce our esteemed panelists. We have 6 panelists today. Dr. Stephanie Seydoux, she is the French Ambassador for Global Health. Dr. Christopher Tufton, who is the Minister of Health and Wellness of Jamaica. Dr. John Mungwiro, the Deputy Minister of Health and Childcare of Zimbabwe. Professor Coco, the Program Manager for the Prevention and Control of Diabetes Project, representing...
Okay.
Sorry? Oh, okay. Professor Stephen Colagiuri, who is the Vice President of the International Diabetes Federation, and Professor Juliana Chan, who is the chair of the Lancet Commission on Diabetes, which was just published late last night. So welcome to all of you. And a brief disclaimer, we're going to keep the panel as long as initially planned because it is incredibly important to hear all of your perspectives. And I'm going to start out with some questions on the challenges that you're all facing in your respective countries. Dr. Tufton, I'll start with you. Jamaica has a high prevalence of diabetes in the 15 and over age group. What are the biggest challenges that the Ministry of Health has faced with regards to diabetes care?
Thank you very much for that question, and good morning, afternoon, and evening to all who are on this panel. The challenges in diabetes care are multifactorial and relate to the healthcare system as well as to community systems. The healthcare system, we have staffing challenges and the lack of use or adoption of technologies to provide comprehensive care, which includes follow-up engagements in between clinic visits, adherence to clinical and non-clinical protocols, nutrition consult, physical activity prescription, screening and management of substance abuse, such as tobacco use, alcohol abuse. Access to care is affected. The community systems at the individual level, there is limited access to self-management support systems such as locally developed applications. The environment is also not enabled as resources and policies to make the healthy lifestyle choices. So the easier choices are always the choices. So cost of healthy foods, access to safe spaces for physical activity. We are, however, addressing a number of these issues. We have a IDB project, as well as initiatives that we promote within the ministry, which are being used to improve the diabetes prevention and care. So in terms of the IDB project, we have locally produced NCD apps that we're creating with the introduction, scale of telemedicine to improve access to primary care and specialist services, electronic health records, which will also give support to technology platform, worker training, and support for implementation of the chronic care model for service delivery. In addition, improve access to diabetes monitoring tests with the rollout of a point of care testing in the public health care system is being developed, and public-private partnership for NCD care, initially focusing on diabetes and hypertension care. And finally, recently we completed interim guidelines for clinical care of diabetes to support the clinical side of our application. Thank you.
Thank you very much, Dr. Tufton. Appreciate that. I'm going to ask a similar question to Professor Coco. With diabetes also having a high prevalence in Myanmar, what are the biggest challenges that you are facing in addressing diabetes?
Thank you very much for the question. As you all know, Myanmar is one of the low-income countries, 54 million people, 70% residing in rural area. So our diabetes prevalence is 10.5 and pre-diabetes is 19.5. This is according to 2014 STEP survey. I'm sure that number will be increasing in next year STEP survey. So according to our census, we estimated that we have 3 million diabetes patients in Myanmar. So our biggest challenge is how we can screen, diagnose, treat, and help them to control. This is our biggest challenge. So in terms of these things, we're doing the 3 level, tertiary level for the Center of Excellence for the referral, and province level, and primary care level, we have a PEN package is covering for the 2/3 of the country. So our bigger challenge that area is limited access to the essential diabetes medication and diagnosis tool and strips, because even though government is supplying the free supply in the hospitalized patient and the rural area people, which are vulnerable, there are many diabetes patients living in Myanmar who has to buy themselves from their out-of-pocket money, nearly 80 to 100% for this medicine, as well as the diagnosis too. This is a big problem with us. So this is a limited access. This is including insulin as well. So we can give freely insulin for the type 1 up to 18 years, and then in the hospitalized patient, not for the outpatient. So there's an outpatient people also have a very limited access to the insulin as well. So these are the challenges. Also, when we're doing the pen package, there are a lot of problems, such as a previous speaker said that it's a, this is a limited access to the diabetic care. We need to increase the population coverage, service coverage. This is a logistics supply chain is not very stable. So that's an interrupted drug supply to the rural area. It can compromise the adherence of the therapy. And we don't have a very good diabetes registry as well. And the data recording, reporting system, and we don't have a surveillance and referral system also weak. So these are the areas we need to improve. In terms of prevention of the diabetes, we need to improve the awareness of the diabetes among the public, because in our country, nearly 80% of people doesn't know they have diabetes, and they don't know how to prevent the diabetes. So there we need more awareness for the diabetes through the media. So we are fighting with the sugar beverage company and high junk food company in the media war, and we are losing because advertisers are so expensive. And then there's also, weakness in the multi-sectorial meeting, in the cooperation between our ministry and other ministry and the civil society as well. And the main thing is a lack of donor or lack of interest of donor in the prevention of diabetes. They usually go for HIV/AIDS, not for our diabetes. These are the problem we are facing in Myanmar now. Thank you.
Thank you, Professor Coco. Those are certainly a lot of challenges, no doubt about it.
Yes, I did.
So following on the pen package that was mentioned several times, Dr. Mangwiro, Zimbabwe also is implementing the WHO package of essential NCD interventions. How is the integration? How is the integration of diabetes and cardiovascular services changing frontline clinical practice and benefiting people living with diabetes?
Yes, good afternoon. That's a very relevant question in Zimbabwe, because once we took it down to primary health care, this means more people and healthcare givers are more aware of diabetes and cardiovascular diseases, be it hypertension, heart problems. So in primary healthcare, more screening will be done for these conditions, both hypertension and atherosclerosis, lipids, and all that. And the pickup for diabetes, patient diabetes disease is much more because it's done at primary level, which is very good for us. And once diabetes and cardiovascular disease are picked up, they are treated early. And this leads to reduction in morbidity, mortality, especially in terms of emergencies, be it DKA, diabetes ketoacidosis, hyperosmolar, hyperglycemic states, and hypoglycemias are looked at very much once they are done at primary health care. And health education also is given much earlier than to wait until people complicate. And complications are also avoided, be it the eyes, the cardiovascular system, the eyes will not lost the ears as well. And the complications, if they come, they are treated early. And once diabetes is at primary health care, it really means that lifestyles will soon change much earlier than waiting for people to go to hospital to have this early done. And people at primary health care level have a chance to look after themselves much better. And community awareness is much higher because most of these primary health cares are in the community, and people with emergencies are brought in early. family and community awareness is an important integral part of looking after patients with diabetes and cardiovascular diseases. In conjunction with this COVID-19, which is there, people have challenges that face them. They can no longer go to hospitals and clinic much easily. So we need to change, the people have changed their health-seeking behaviors. So to overcome this, people were resorting to the media, be it TV, radio, printed media. And we are also making people aware that diabetes and COVID can really move together as good friends, because once you have diabetes, COVID is a metabolic disease as well. COVID-19 is a metabolic disease, we all know that. And that DM patients already have immunosuppression because of the chronic inflammation of diabetes. So COVID will also disturb their immunity. We spread these things in all our local languages, mainly our English, Shona, and Ndebele, so that our communities and society understand us. And health care workers, really at primary healthcare level, we take it for granted. Healthcare workers need to be taught and trained properly about how to look after diabetes and diabetics, and how to tell people and to let them understand the connection between COVID and diabetes, because COVID-19 itself is a disease that causes massive immunosuppression and can lead to fatal diseases together with diabetes. It can lead to strokes, problems with eyes, the heart, the kidneys, the liver, and peripheral neuropathy. So our biggest problem now is that most patients cannot afford most of our diabetic drugs, and they are not following up with their glycosylated hemoglobin because of the expense. Because now with the COVID, most of these drugs are now difficult to come by. And when they are found, they are quite expensive. So we hope that we'll find a way of starting to produce some of these drugs locally, or make sure we are get assistance to make sure we are getting these drugs, including insulin, much cheaper, because people, once they become aware, they want a solution to their problem. So making people aware at primary healthcare level about cardiovascular diseases and diabetes is a very good thing. So we have to go along and make sure treatment is also cheap and readily available for these people. So as does COVID, we need also to know that COVID may be around to stay with us, and diabetics are at a much higher risk because their immunity is already much lower. And we know diabetes is a chronic inflammation disease, which does the same thing as COVID-19. I'm sure with those I'm done. Thank you, Madam.
Thank you very much. Yes, and along the lines of the cost of care, which, of course, comes up very frequently, Ambassador Sidhu, with next year marking the 100-year anniversary of insulin, a real milestone, can you share your views on scaling up affordable access to life-saving insulin in low and middle income countries?
Well, thank you very much, Dr. Kalembrick. It's a great pleasure to be on this panel with the honorable ministers who just spoke from Myanmar, Zimbabwe, and Jamaica, and with distinguished professors. And I would also like to greet all the participants online. And finally, of course, thank the WHO, Dr. Tedros, Dr. Bente Mikkelsen for organizing this important event. It's important because tomorrow is World Diabetes Day, and many events have already been programmed around the world for the special day. We have today heard very powerful testimonies, and speakers have explained how hard it is to go about fighting this disease in the current context. This is, of course, an issue of very high costs, generating out-of-pocket expenses, access to quality products, not only the insulin itself, but diagnosis and technologies, the strips, of which there's been much talk until now. And of course, the most worrying and unacceptable fact that there is a gap between the types of technologies which are available to patients in richer countries and what patients strive to obtain in other countries. And this gap is growing, aggravated by the current crisis. We've had many speakers, Dr. Ren, the minister from Jamaica, just now, his predecessors in the talk, point to the very alarming consequences of the COVID-19 pandemic, particularly on people who are vulnerable from other diseases, and diabetes is one of them, particularly at risk, and also suffering from the general disruption caused in health. And may I say so, even in countries which are not themselves affected primarily by the COVID epidemic itself. So I believe that we share the same understanding and analysis of the situation. And we know the solution, and that is to make equitable access effective. And we believe that with political support, multilateral efforts, and civil society mobilization, this will happen. Now, we've seen the devastating effects of the COVID-19 crisis on health in general, and in the fight against or for health for people suffering from diabetes. There has also been something that we can build on, and that is the multilateral response to the COVID-19 crisis, which is actually setting a precedent. The ACTA, Access to COVID-19 Tools Accelerator, which took off under the auspices of the WHO and many other health organizations, has reaffirmed at the highest level the principle of equitable access to health products. And this was reaffirmed yesterday with the notion of the public common, the global public good that must prevail in the fight against COVID-19, and that was reaffirmed by our president yesterday during the Paris Peace Forum, which you might have seen. Now, this level of mobilization and this principle gives an idea of what could be done for insulin, and insulin being a 100-year-old product, which has long proved that it is safe and efficient. So there are strong levers that we can rely on. Now, the right mobilization is underway, and today's event is a proof to that, with a very strong commitment from WHO, which provides the best leadership to build larger partnerships. I also want to underline how civil society organizations are mobilized and give tribute to Médecins Sans Frontières, Doctors Without Borders, with its access campaign, as well as Santé Diabète and the International Diabetes Federation, and others who are doing a tremendous job in the field and also in advocacy grounded in expertise and outreach. Of course, governments, which are very strongly mobilized, as we heard from the previous ministers speaking on this panel. Now, also many tools exist. Just want to quote the role played by Unitaid, which is an innovation agency which looks at how bottlenecks and difficulties prevent access and find legal paths in terms of technical market solutions as well as social innovation. And we've seen how innovation can play a part. Many examples quoted by the minister from Jamaica, and also from the other ministers, on how a people-centered approach with social innovation is absolutely key in guaranteeing access. And finally, I want to also build on what was alluded to by, and quite powerfully by Vicky in her testimony, which is the fight against other diseases, particularly the communicable diseases, and particularly the very strong mobilization against HIV, malaria and tuberculosis. Well, there were lessons learned, as well as it's work in progress in strengthening health systems, supply chain, data system, which the minister from Myanmar alluded to. Now, France will be active to put these important issues regarding diabetes and access to insulin on the agenda of the next World Health Assembly, including on a resolution project, which we are interested in working on and until it gets to an outcome. Now, we need to show ambition in the fight against non-communicable diseases. We will propose realistic solutions such as, and I will quote 6 of them: stronger national policies for prevention and care, inclusion of civil society organizations and people living with diabetes in the development of national guidelines and implementation strategies, locally produced cooling devices, access to affordable technologies, strengthen health systems, particularly diabetes services and insurance or funding mechanisms, and finally, fair prices of insulin doses and transparency on prices. And definitely France will call for a global mobilization for the 100th anniversary of the discovery of insulin.
Thank you very much, Ambassador Seydoux. Professor Caligiuri from the International Diabetes Federation, with access to insulin having been such a challenge for such a long time, what makes you hopeful that we will turn the situation around before another century passes? And what have we been missing so far?
Thanks, Sylvia, and thanks very much to WHO for the opportunity for the International Diabetes Federation to be part of this important event. So there are many reasons why IDF is confident that the current situation with lack of insulin access can and will be turned around in a relatively short period. Indeed, the fact that we are here today is a sign of hope. So just to highlight just a few, because we're running out of time. But firstly, the centenary of insulin has provided a global focus on the entirely unacceptable situation whereby several million people with type 1 diabetes are not alive today because they do not have sustained access to insulin and the care they needed to survive. As a result, we are seeing increasing international solidarity and recognition of the moral imperative and urgency to change this. Secondly, I think in the past there has not been a sustained collaborative effort from all the stakeholders involved in improving access to insulin, but there now seems to be a willingness for these many groups to unite and to coordinate efforts. As we saw in the recent WHO access to insulin workshops, there are many successful activities already underway that we can build on and extend. And in particular, there seems to be an increasing willingness for insulin producers to acknowledge the problem and engage in the process to find sustainable solutions. The two largest global diabetes NGOs, IDF and the Juvenile Diabetes Research Foundation, have joined forces and together with the NCD Alliance have come together to drive action for change. Thirdly, and as we've already heard earlier, until now we have failed to harness the voice of people with diabetes, which after all, I think and we think are the greatest but underutilized resource in bringing about change. And finally, I think that the International Diabetes Federation is actually confident that the Global Compact will facilitate increased joint collaboration and add momentum for the action for full access to insulin for everyone who needs it.
Thank you very much for your encouraging words. And Professor Chan, first of all, congratulations on the publication of a true masterpiece. So with the publication of the Lancet Clinical Diabetes Commission, what innovative approaches does the Commission recommend that could be quickly implemented in lower and middle income countries?
Well, in this really very large report, 66 page, right? It just really represents the large body of knowledge that has been gathered over the years. And in this report, we have summarized some very good practices actually all around the world. As we already heard that, there is an urgent need to close the gaps in prevention and care. But we also emphasize very much to close the gap of the knowledge, the professional knowledge and the data, because these two important factors are critical in delivering care. We've already heard that people with diabetes need education. They need education to help them self-manage. And over the last 20, 30 years, the knowledge that has been amassed by the scientific community is huge. For example, there are like 9 drugs, right? There are technologies. And I mean, there is a gap, in terms of this knowledge being translated to, for example, doctors, and from the doctors, and then we need the nurses, the dietitians, and also even sometimes we use the community workers, the peer supporters. I think without that workforce, right, it is very difficult to translate that evidence. On top of that, while we have all the, while we actually ensure that people have that medications, insulin as well. But I think, non-adherence, awareness, lack of awareness, these are important missing pieces. And we need the healthcare team to actually mobilize to do that. And secondly, it's also important that, diabetes is silent, and therefore the ongoing structured data collection as part of the routine service that these people periodically have their eye looked at, the feet looked at, the blood and urine, get that data systematically collected and use that data to actually empower the patients to stratify risk and prioritize care, and to help doctors make decisions, for example, the use of medications, and that will actually ensure that these people are getting what they have. Then on a system level, these data are very powerful in terms of benchmarking performance, providing quality assurance, and also identifying gaps, and for really sharing of best practices. And finally, I think, over time, people can track, what is the trend, and that is whether it's decreasing. Are there certain diseases, for example, heart disease is getting better, but then we are seeing emergence of like cancer becoming important cause of death now in people with diabetes, dementia, etc. At the same time, we are seeing emerging trend of young onset diabetes, and these people, whether they're type 1 or type 2, they've also have really needs, for example, the psychosocial, etc. So that's the reason the title is data. We use data to transform diabetes care and lives with diabetes. So, I think this is really, the essence of this report. It's a 4-year work, right? 44, experts. These are people involved in clinical care, in epidemiology and economics, and we do modeling to try and really demonstrate that if, apart from access to medications, but with this data-driven integrated care, we can really, save millions and billions of dollars. And we call on the government, the funding agencies, right, whether they're private or public sectors, to align, right, so that, they work, to make sure that this total package, not just the medications, but the care and the education and the support and the data system to be put in place in order to protect these people and prepare them, so that they are not just for the future complications like 10 years down the line, but for example, emergency like COVID-19. So I think that is really, a large body of work, and we hope that, whether they are policymakers, whether they are payers, or whether they are practitioners, they will find something, messages and aspirations that are very relevant to that, and we align that so that, we have the people with diabetes and those at risk, who benefit from that knowledge.
Thank you very much. Okay, we have one last question for Dr. Tufton. Now, with the Global Diabetes Compact launching soon, in your opinion, how can it best support countries in the Caribbean region in improving diabetes outcomes?
Thank you very much. Are you hearing me?
Yes. Yeah.
Okay. Right. So the WHO Global Diabetes Compact, which aims to bring together national governments and a wide range of partners around the shared vision of a world where all people living with diabetes can access the care they need. And of course, the compact has various aims supporting countries to accelerate, reduce major diabetes risk factors through population-based policy, improve coverage of quality diagnosis, scale up access. This compact can be used to accelerate programs for the prevention and control of diabetes at all levels, and certainly for us in the region. At the population level, advocacy for policies and fiscal measures can be strengthened with tailored to focus on policy positions, including most cost-effective WHO best buys for NCDs, such as food reformulation for salt, sugars, and trans fats. And in fact, we've started that in Jamaica by commissioning baseline studies to look at trans fats, salts, sugars in our foods as a way to push for things like front of package labeling so that persons will know exactly what they're consuming and what the consequences of overconsumption or in those areas would be. Caribbean countries are challenged, of course, with maintaining access to essential medicines, and we believe that should be prioritized for financial and supply chain management support to ensure uninterrupted access to medicines, and that's something that we need to work more on. We can, as Caribbean countries, provide with technical assistance to fast-track design, implementation of the UHC and national health insurance schemes, which can reduce or eliminate out-of-pocket cost for the most vulnerable populations. In Jamaica, we have our National Health Fund, which does provide free drugs, but we need to make that universal and ensure that it covers adequately all the needs in that area. And learning exchanges between Caribbean countries with other countries with similar NCD profiles, I believe is important, as well as with countries which have had success in implementing major changes in their health systems, which are showing promising results, I believe can be facilitated under this compact. So these are just a few of the critical areas. I've chosen the ones that I think may be most important, but there are others. And we recommend or commend these for consideration as we go forward. Thank you, Madam Chair.
Thank you very much, Dr. Tufton. And I wish we had more time to ask all of you more questions. We could have this conversation for hours, but unfortunately our time today is limited. But I want to thank all of you panelists for your words and your wisdom and your perspectives. We truly appreciate it. And so the next part of our agenda today is a video message from the University of Toronto with Professor Daniel Drucker.
My name is Daniel Drucker, and I'm a senior scientist at the Lunenfeld Tannenbaum Research Institute at Mount Sinai Hospital at the University of Toronto. This year, we will celebrate together the 100th anniversary of the discovery of insulin. At the University of Toronto, we will host a special scientific symposium, Insulin100.com. In keeping with the spirit of Banting, who made the patent for insulin available to the University of Toronto for $1, we will also encourage global access to our meeting by making registration and abstract submission free. Banting realized 100 years ago that in order to deliver and supply insulin to as many people across the world as he possibly could, he would need to form partnerships with industry and governments all across the world. We have made tremendous progress over the last 100 years. We have new medicines, new healthcare technologies, and tremendous advances in healthcare infrastructure. Yet, as COVID-19 so painfully reminds us, people with diabetes remain vulnerable, particularly when they have suboptimal access to the best healthcare. To this end, the University of Toronto celebrates the WHO Global Diabetes Compact. It is only through this type of partnership with private sector, governments, and people with diabetes that we can hope to meaningfully improve the lives of hundreds of millions of people with diabetes all across the globe. Whether it through the delivery of healthcare, enhanced delivery of technology, or making medicines more affordable, there is much to do over the next 100 years. Working together, I am certain that the WHO can mobilize all sectors of our global community and truly make a difference for people with diabetes. The University of Toronto congratulates and celebrates this new WHO initiative, and we stand ready to make the next 100 years even more meaningful to improve the lives of people with diabetes all across the world. Thank you very much.
Thank you very much, Dr. Daniel Drucker. And what a celebration. Thank you so much. I wish we could stay on for hours. And like Dr. Tedros usually say nowadays, together. And I think we have demonstrated that nothing for us without us. And it was a pleasure to hear the strong voices of people living with diabetes, the strong voices of ministers, ambassadors, people that really have to make all these decisions every day for the population they serve. And we really want to focus on the things you have emphasized, the access, the equality, the education, the learning from others, the possibility to use data and use data to action and to improve the life for all people living with diabetes and also to prevent for the future. So I thank you so much. Thank you to a fabulous moderator, Dr. Sylvia, and thank you all. And thank you, Dr. Ren, for being with us here today. Have a really nice day. And as you know, there is a launch of the Lancet Commission coming in an hour with our excellent Professor Juliana Kahn as a moderator. So please join us in the next session as well. Thank you.
Thank you very much. Thank you.